Dr. Aarti and Dr. Neera.
Okay. Okay. Hello, Dr. Aarti, Dr. Meera.
Hello, ma'am.
Yeah.
Hello, ma'am. Good evening.
Good evening, dear. We will start sharp after 9.
It's 9. Can we start or we are waiting?
No, we will start now.
Start?
Yeah, we can start.
Okay. So, very good evening to all of you. On behalf of NIMA Central and NIMA OBGY Central, I welcome you all to the 60th webinar. Today's topic is FGR and its recent advances by Dr. Meenal Dole, ma'am. Myself, Dr. Aarti Kulkarni, and I'm coordinating today's webinar with my co-coordinator, Dr. Neera. First of all, it's my great pleasure to welcome all the honorable dignitaries present on this virtual dais. I welcome Dr. Kamini Dhiman, ma'am, President NIMA OBGY Central, Dr. Priyanka Nakade, ma'am, Secretary NIMA OBGY Central, Dr. Vishnu Bhavani, sir, Treasurer NIMA OBGY Central, Dr. Rajesh Utani, sir, Convener NIMA OBGY Central. Also further, I would like to welcome all of his bearers of NIMA Central and state bodies. I wholeheartedly welcome all the participants attending today's webinar. Welcome all. Let me brief everyone with few instructions to maintain decorum in today's lecture. Kindly register with name as written on NIMA OBGY membership registration certificate followed by NIMA OBGY registration number. Please don't hesitate to put your doubts in a chat box or you can raise your hand. All doubts will be answered at the end of the session. Proceeding further, we are now virtually going to inaugurate this webinar with Dhanvantari Stavan. Everyone, please join your hands, close your eyes, and pray and seek blessings from Lord Dhanvantari. Namami Dhanvantarimadhidevam Suraivanditapadapadmam Loke Chararu Bhayamrityunashanam Dataramisham Vividhaushadhinam. May Lord Dhanvantari bless us all with good health, success, and prosperity. Now, I would like to brief everyone about NIMA OBGY agenda. NIMA OBGY, that is National Integrated Medical Association, Obstetric and Gynecological Society of India, aims to impart education in supporting and protecting the character, status, and interest of the integrated medical profession in practitioners of Sri Rog and Prasati Tantra. NIMA OBGY is committed to promote services for betterment of health of the community, especially maternal and child health, prevention of ailments and diseases, the treatment and integrated approach of Indian medicine with modern science. So the subject of today's webinar is FGR in recent advances. Nowadays, the prevalence of complications in pregnancy is high. In our day-to-day practice, we come across many such patients with high-risk pregnancy. So, and one of the common complication is fetal growth retardation. So, today's webinar subject is fetal growth retardation by Dr. Meenal Dole. She is consulting obstetrician and gynecologist and ART consultant, as well as laparoscopic and endoscopic surgeon practicing since last 20 years at her hospital, Dole Hospital in Amravati. She also has special interest in preventive oncology. She has completed MBBS from Government Medical College Nagpur, DGO from SMBT, FMAS from World Association of Laparoscopic Surgeon, and also completed LLB from Amravati. She has worked as a district women's hospital as she has worked at District Women's Hospital as a medical officer for 3 years. She is member of Society of Fetal Medicine, member of Indian Association of Gynecological Endoscopy. She is the executive member of Disha, which works for needful girls and women. She is the brand ambassador of Until You Speak. So she has special interest in social issues as well as law and medicine. So let's welcome our today's eminent speaker, Dr. Monali Tole. Please start, ma'am.
Yes, thank you for the nice introduction, Dr. Aarti.
Thank you.
A very good evening, all of you. So happy, Dr. Sharayu, give me this opportunity to talk before you, the esteemed guests, the members of NIMA. Thank you so much. Today's topic will be FGR. This topic, she was insisting me to take some topic of my interest. I insisted on taking this topic. This is because the incidence of FGR, or you can say a fetal growth restriction, has increased significantly in few years. And we need to address this issue is because there are many cases wherein we are facing IUDs in last month. We are facing deaths, neonatal deaths in the NICU. Plus, we want the morbidity and mortality of the children as less as possible. We don't want the babies to be restricted, delivered. We don't want the babies to be mentally challenged, delivered. We don't want mentally challenged babies. We don't want crippled babies. We want healthy baby, which is healthy physically and mentally, without any diseases. So that is the target for the obstetricians, to give a nicely oxygenated baby to the mother after the delivery. So let us start with today's topic, that is FGR. So this is the kind of baby everybody wants in her lap. Every mother wants in her lap a baby walking, talking nicely with having a nice pincer grasp. This is a normal baby. Now you may have babies like this. This baby is a normal baby. This is IUGR baby. This is also an IUGR baby later on in the life, because these babies are IUGR babies. How? Because many of it has been seen that many of the IUGR babies are landing up with the NCD diseases later on. NCD diseases means patients with diabetes, patients with hypertension, patients with cardiac disease, and patients with malignancies. All these diseases, they have their beginning since their childhood. So let us come to the topic. What is FGR, or what is fetal growth restriction? Fetal growth restriction, also known as intrauterine growth restriction, is a common implication of pregnancy that has been associated with a variety of adverse perinatal outcomes. Now, what is these two are different terminologies. What is SGA? SGA is small for growth. SGA, it would be based on growth percentiles, and FGR, that is restricted baby, would be based on evidence of pathological growth. What is the fetal medicine definition of FGR? Growth restriction we defined as estimated fetal weight less than 10 percentile and or the AC, or the abdominal circumference of the baby less than the 10 percentile, will be a FGR baby. Now, what is the consensus-based definition for FGR? There are two types of FGRs. It is very difficult to distinguish between the early onset FGR and the late onset FGR because many patients are in between the two. But let us try to simplify the things. What is early onset FGR? Early onset is FGR is the one which sets in or which is diagnosed for the first time before the 32 weeks. On the contrary, what is a late onset FGR is the FGR which is set in or which is diagnosed for the first time after 32 weeks of pregnancy. And what is early onset FGR? Again, the definition, effective fetal weight or the abdominal circumference is less than third percentile. In late onset, the same thing. In early onset, along with the effective fetal weight and AC, you see the uterine artery Doppler with AREDV means when you go for a color Doppler for such patients, you can see the reverse diastolic flow in the umbilical artery that is used along with the effective fetal weight and the abdominal circumference. In the late onset, there are more than or two of the following three criteria, that is effective fetal weight or abdominal circumference less than the 10th percentile. B is the effective fetal weight or abdominal circumference crossing percentiles of more than 2 quartiles on fetal growth percentiles. The C is the CPR ratio that is less than 5th percentile or umbilical artery PI more than 95th percentile. Do not worry for all these things. I will simplify it later on. And in the early onset FGR, the effective fetal weight or the AC is less than 10th percentile combined with one or more of the following criteria, that is umbilical artery PI more than 95th percentile or the uterine artery PI more than 95th percentile. Now, all these things you do not go into the detail. The only thing you need to see is you need to read the for all these things to understand, that is box 1 of the fetal growth restriction, which is very important from your point of view. Whenever a sonographic report comes to you from a learned sonography specialist, that is one who is well versed in doing the color Doppler studies, because again the color Doppler studies has to be done very meticulously. It has to be done by a very well versed radiologist who is well versed in doing the color Dopplers, because color Doppler has to be done, it's a different matter. Nobody is well versed in doing a color Doppler. Whenever report come from a best center, you just need to read it nicely. All these things which are given here, once you read the report after this lecture, you will understand it nicely. What you have to read? Just you have to see the charts they have given in the report. The chart has on one side reference values. The chart on the other side, just beside the reference values, has the values of the patient. So read the abdominal circumference. That is very important when you think or talk about FGR, and read the effective fetal weight. Please do not read the EDD. The EDD has to be decided only by the LMP of the patient if patient's periods are regular. EDD is never determined by the sonography if it is done after 20 weeks of pregnancy. EDD is best determined by the LMP of a patient if the patient's cycles are regular. If patient cycles are not regular, EDD is defined by the scan at 7 weeks, 12 weeks, or at max 20 weeks. Any scan after the 20 weeks can never determine the EDD. If any sonologist fellow of yours is giving EDD in her sonography report by the USG, it is written something, just read it nicely. EDD by USG, just ignore that. Actually, the ultrasonography people or the sonography people are not supposed to write EDD by USG in their reports. But I again come to the same point, that report usually in a busy OPD of a radiologist is typed by most of the times the technician, and he read the thing on the chart and it makes it. Actually, the report and the interpretation needs to be written by a radiologist. Then only the person reading the report can read it nicely. Even though some radiologist has written EDD by USG after a sonography report which has been done after 20 weeks, just ignore that. What you have to read, if you want to determine the EDD of a patient, you need to have a sonography report of 7 weeks, 12 weeks, or at the max 20 weeks. After that, all the sonography reports, whichever will be done, will never determine the EDD. They are only done for the growth scans, for the Dopplers, for the growth, and for the monitoring purposes, and for the detection of any anomalies if they are going to get present in the latter weeks of pregnancy. So, for the EDD, you just have to concentrate on the sonography report, which has been done before 20 weeks, or the LMP. Never read EDD by USG after 20 weeks of pregnancy. This is the main message of my today's lecture. Please do that. Because patients are very intelligent, they are they have Google doctors with them. They read the reports on their own. Actually, they are not supposed to read the reports, and they don't understand how to interpret the report. And then they come with the conclusion that my EDD is changing in each sonography report. Then it is your duty, our duty, whosoever is reading the sonography report, to tell them that EDD is never determined by the sonography report after 20 weeks. It has to be determined again by the sonography report before the 20 weeks, or the LMP of a patient if the periods are regular. I hope I am clear on this point. Now proceed. Now, once you have determined the EDD, now you concentrate on the graphs which are coming with the report, or the figures which are coming in the report. If you see the AC, the percentile is also coming in written. Effective fetal weight, the percentile is also coming written in a very smart ultrasonography report. You can read that. And if you can see, remember these percentile figures for the AC or effective fetal weight, they are the only two things which are going to help detect the fetal growth restricted baby, and you can then give the treatment accordingly. Now again, come to best practice advice for screening, diagnosis and management of fetal growth restriction. Early onset versus late onset FGR. It has been suggested that FGR should be broadly classified based on the gestational age at the time of diagnosis into early onset and late onset. The rationally underlying this classification is based on differences between the two phenotypes of FGR in severity, natural history, Doppler findings, and association with hypertensive complications, placental findings, and management. What does this mean? This means that the reasons behind early onset FGR and late onset FGR are different. Maybe some reasons may coincidentally can be similar, and natural history is also different. Doppler findings are also different. Hypertensive complications are different. Placental findings are different, and management will also be different, which I will elaborate in the slides in next few minutes. So, in early FGR, which are mostly 30% of the cases, and late onset FGR are usually 70% of the cases. Yes, the screen was coming in between. I wanted this to, what happened? Presentation has gone somewhere. Yes. In the early onset FGR, the fetus may be very small. Rather, in the late onset, fetus not necessarily very small. In the early onset, the placental disease is higher. In the late onset, placental disease is in lower incidence. Abnormal umbilical artery, uterine artery is higher in FGR. In late onset, it is low. The PI values or the incidences of preeclampsia is more in early onset. It is lesser in late onset. The hypoxia is more in early onset. It is not much in late onset. Tolerance to hypoxia is good in early onset. Rather, it is very, very poor in late onset cases. I don't know, something has happened. And the next slide is not coming. Let's start it from beginning again.
Yes, ma'am.
It has got logged somewhere. Huh? I will start it again.
You can start from first and
हाँ
then
मुझे ऐसा लग रहा है. I don't know. It is not
Mhm.
going. It is not going. It is not going. I was trying to reduce the participants' screen that was coming in my screen. I was trying to do that, but something. Share. Yeah, it is coming.
It is visible, ma'am.
Yes, yes, but it is not coming on the screen, no? Bigger screen. Yeah. So the common etiologies of fetal growth restrictions are usually the suboptimal uteroplacental perfusion of the fetal nutrition. A are the maternal factors, which are very, very important. Usually the chronic lung diseases like asthma or the restrictive disease like emphysema or the patients living at very high altitude, anemia, smoking, substance abuse, malabsorption, poor weight gain, environmental toxins like air pollution, heavy metals, and others. In the placental factors, the maternal vascular malperfusion pathology like infarctions. Here comes the bleeding in first trimester or something like that. Fibrin deposition, chronic abruption, fetal vascular malperfusion pathologies, chronic placental inflammation, and confined placental mosaicism. All these, whatever things I'm telling placental factors, here comes all the diseases like SLEs, patients having BOH, patients having abortions, patients having bleeding issues, patients having pain in abdomen off and on. All these pathologies comes in this criteria. Now the umbilical cord factors, the increased coiling, the increased cord length, the true cord knot, the single umbilical artery, the marginal or filamentous cord insertion. Then the risk associated with the fetal growth restrictions are, for this we are discussing this topic today. Antenatally, what we can see, sometimes patient comes with stillbirth. We don't have anything in hand. The previous slide, the reasons I was telling you, even if there is no growth restriction right now, see, this is because a medico-legal era. All patients are sitting there to sue you in the court, right? So let me take you to the earlier slide. This, right? You have seen this hypoxemia, anemia, smoking, malabsorption, pollution, then the vascular perfusion pathologies like bleeding and anything like BOH, like confined placenta mosaicism, like abnormal babies, like coiling, like knots, like symbolic umbilical artery, marginal insertion. Whenever you see all these reasons, no, you start talking to patient in their language. What? That this baby may, you don't, patient ko darana nahi hai, but you can tell them that the patient may have these complications in future. You need to be extra careful in this pregnancy, because every time any patient come to your ANC OPD, no, the question is, madam, sagan normal ahe na? Your answer should be no. Don't पेशंटला खुश करण्याची आपल्याला काही एक गरज नाही. This is because if this stillbirth happens, right? If stillbirth happens, if preeclampsia happens, if placental abrasion happens, if preterm birth happens, who is responsible? If neonatal morbidity happens, mortality happens, they will come again to you and they will question you, तुम्हाला आधी समजलं नाही का, तुम्ही आम्हाला अलार्मिंग साइन्स का दिल्या नाही, किंवा तुम्ही आम्हाला का सांगितलं नाही. Here comes the role of a counseling. Whenever a patient comes with a high risk, you should tell them that along with all the medicines, whatever we will be giving them, they need to take TLC. What is TLC? TLC is tender loving care. Patient has to be low profile. Patient needs to take bed rest. Patient needs to take patient needs to be ambulant. Patient need not be do exertion. Patient and her family should be involved her ANC care. This is because to avoid stillbirth, preeclampsia, placental abruption, preterm birth, and in neonatal time, neonatal mortality, morbidity in the form of hypoglycemia, hyperbilirubinemia, hyponecrotizing enterocolitis, respiratory morbidity, and intravascular hemorrhage. All these complications are seen more and more in cases of fetal growth restricted babies. So you need to prepare the mind of a patient in that way, because sometimes suddenly if something happens, you should be in an answerable situation that I was telling you, baby, that this was the reasons you were supposed to take the precautions. Otherwise, you may end up in this complication. So you are at some place, safer place to counsel the patient. You are at a better position, right? So again, the long-term risks associated with fetal growth restrictions are the neurodevelopmental disorders like dyslexia, like irritable babies, you know, like autistic babies. All these have their beginning in the growth restricted babies. That is why I showed you the very first slide wherein one baby was very small, one baby was very mota, because that is a metabolic syndrome. Obesity, hypertension, diabetes, and cardiovascular diseases, all these diseases have this origin in the intrauterine life. This is more and more well accepted nowadays. All these diseases have their origin in intrauterine time. So it is a responsibility not only of a mother but the family to take nice ANC care of the patient by the family. So everyone should be involved in her proper care. Now, what is the early prediction and prevention of fetal growth restriction? Early prediction of FGR is very, very important, as it can identify women at high risk of FGR who may benefit from preventive interventions and close monitoring during the pregnancy to avoid the complications and to reduce the incidence of the FGR babies. Now, there are certain biochemical markers which can in some way tell you that this baby may have some complications or may end up in complications. Like at this point, there is no role for routine screening with serum biomarkers for FGR as such. However, biochemical markers when biochemical markers are available as part of prenatal genetic screening for trisomy 21, it may be reasonable to use this information for the purpose of risk stratification for FGR. The placenta releases multiple factors into maternal circulation from the early stages of pregnancy, and first trimester serum levels of some of these factors have been shown to be associated with subsequent placental mediated complications. Low levels of pregnancy associated plasma protein, that is PAPE, placental glycoprotein produced by the syncytial trophoblast layer, have been associated with the adverse pregnancy outcomes, including the AGA, that is the small growth restricted babies. Now with new ANC, I hope everyone knows it. If not, please make it very, very clear that in a routine screening of the ANC patients, we're supposed to do the double marker test of all the pregnancy, all the babies from 11 weeks to 13 weeks of pregnancy. We're supposed to screen each and every patient for trisomy 21, 18, and 19 from 11 weeks to the 13 weeks. That test has to be done from 11 weeks to 13.6 weeks. The test is done along with a sonography that is called as NT-NB scan. That is the nasal translucency and nasal bone scan along with a double marker test. Now, as the test is costly, Some patients may not be in a position to do the test. That is okay and fine. But our duty is to counsel the patient. We can ask them, we can tell them, this is the test available for the patients. You should get it done. If you are not willing to do that test, that is the ball is in their court. That is their responsibility. But you should take it in return on your ANC notes or somewhere. If you are keeping a record of a patient, you should write it down that this test is necessary. That is an NTNB scan and a double marker test between 11 weeks to 13.6 weeks. And if the patient is not willing to do, patient should give it in return that I am not willing to do or I don't want to do it. Because if something happens or if sometimes the baby get delivered as a trisomy 21 or Down syndrome, the patient can sue you for that reason because we are supposed to do that test. It is a mandatory test. It has come in a routine screening for all the ANC patients. Now the ultrasound markers. Several ultrasound-based markers have been shown to be predictors of FGR, including the uterine artery Doppler, placental morphology, and amniotic fluid volume. However, given their modest predictive accuracy, they cannot or can be recommended for universal screening for the FGR. Now, let us come to the FGR latest research and clinical implications. Our role is to identification of a small fetus, distinguish between FGR and a small gestational age fetus. These are two different terminologies. I have told you in the very beginning. SGA is a very different baby. FGR is a very different baby. Because on that, we will determine the follow-up and the timing of a delivery of a baby. Now, detection of a late onset small fetus can be done by the fundal height. It has a predictive value of 20%. Can be done by the fetal moment. It has a predictive value of 40%. Along with that, if you do the Dopplers, it has a predictive value of 60%. Now, when you go for a cross-sectional studies, it is always better than the growth velocity for identifying the small fetus. What does that mean? That means you have to take cumulative study of all the things together and then you have to diagnose the FGR baby. Now, the detection of early versus early onset small fetus can be done by the Dopplers. How? Biometry. Biometry means you call it as a biparatal diameter, head circumference, femur length, and abdominal circumference. That is a biometry. When we take all the diameters in a one scan, and then you corroborate those with the Dopplers, you can predict the FGR babies very nicely. If not, at least biometry, a single ultrasonography of biometry at 20 weeks, 28, 32, serially at 37 can detect a SGA baby versus FGR baby nicely. जितना भी नहीं, अगर अपने को नहीं समझ में आ रहा है तो कुछ नहीं करना है. Just compare the BPD, HC, AC, and femur length at serial ultrasound scans at 28, 32, and 37 weeks. If they are lagging behind, that means baby is small for growth or baby is FGR. You can direct the baby to the consultant. They will take care of the other things. But you can readily read the report of a sonography person and you should read the report very, very intelligently because reading the report will make you understand if the baby is lagging in growth or not. Just one scan at a time doesn't have any value. You have to have a serial scans because then only you can compare if the baby is growing or not. उसके साथ the very, very important thing is mother's weight taken on a single ultrasound, taken on a single weighing machine. If you take the weight of a patient on a single weighing machine, that if she is gaining weight nicely, then it is well and good. If she is gaining weight haphazardly or too much, that is abnormal. And if she is not gaining weight, that is also abnormal. In both the cases, baby can be FGR or patient may be landing up in preeclampsia, eclampsia, or a diabetes patient. Now to distinguish between FGR and SGA. Now, first of all, why do you want to distinguish? We want to distinguish is because the small growth babies may be constitutionally small. Means if the parents are smaller, mother and father, baby may be constitutionally small, right? Not all HGA babies will be FGR. Some HGA babies will be FGR, some may not. So if the baby is SGA, that means क्या होगा इन babies में? In the SGA baby, if it is small, and if you are taking ultrasound at 20 weeks, 28 weeks, 32 weeks, and 37 weeks, the serial scans में growth अपना comparatively same होगा. या फिर she will be growing nicely. बीच में lagging behind नहीं होगा. On the contrary, FGR में patient का growth बीच में कहीं रुक जाएगा. ACU रुक जाएगा. उसका बीपीडी रुक जाएगा, राइट. बट इन एसजीए बेबी अगर छोटा होगा तो 20 वीक्स पे ही छोटा होगा. उसके बाद लेकिन अगर उसको 20 वीक्स पे लाइक से द चार्ट्स आर ऑफ 20 वीक्स 18 वीक्स 2 वीक्स का लैग है. अगर वो आता है 32 वीक्स पे तो उतना ही लैग आगे जाएगा, उससे ज्यादा कम नहीं होएगा. सो इट इज स्मॉल फॉर gestation age babies. These babies will have better perinatal outcome, rather normal perinatal outcome. This baby will have no fetal deaths. If the baby is a SGA babies, these babies usually will not have IUDs anytime, right? And these babies will not show any signs of adaptation. Signs of adaptation means if the babies are SGA babies, these babies Dopplers will come normal. Dopplers will not come abnormal because these are constitutionally small babies. That much blood which is coming from mother to the baby is sufficient for her, and she need not, the uterines or the umbilicals or the MCAs need not be adapted. On the contrary, in the FGR babies, there will be poor perinatal outcome. Poor perinatal outcome means babies will need admission, babies will come with meconium, babies will need CPAP in the postnatal time, babies will need more time in NICUs, and babies can have IUFD, that means fetal deaths. Many of the times, patient come with ultrasound report which shows that baby is dead. 15 दिन पहले डॉक्टर को दिखाया था, सब अच्छा था, एंड नाउ दिस बेबी इज डेड. ऐसे डेड नहीं होता है बेबी. ऐसे डेड सिर्फ एक ही केस में होगा जब देयर वुड हैव बीन अ कॉर्ड अराउंड नेक. दैट टू लूज कॉर्ड अराउंड नेक डज नॉट हैव एनी सिग्निफिकेंस. If cord around neck would have been tight and patient has got baby has got strangulated, then only this baby will die. Otherwise, if a baby is coming with IUFD, definitely there would have been some changes in the Doppler, some changes in the growth, and baby must have been FGR babies, or mother would have been eclamptic, mother would have been pre-eclamptic or hypertensive, diabetic, or if she may not have been now, she will represent it later on in her lifetime, say after 10 years, 5 years, or say after 15 days. The signs in the babies come earlier, the signs in the mother come later. Many of the times, I am delivering babies in my daily day-to-day practice at 36, 37 weeks. Blood pressure is normal, but I have to go for section because I know this baby is FGR. This baby will die utero if I don't take care of these babies. And definitely this mother comes with a hypertension later on after 10 or 15 days. And but our role is to save these babies. So to save these babies, our motto is to diagnose the babies with FGR at the earlier stage, because the NICU is better for the baby than baby dying in utero. This time, the NICU in utero for the baby is dangerous. Our duty is to take out the baby earlier, and our duty is to have that balance when to take out the baby earlier. We will take out the baby earlier only when we will understand when this baby is going to die, or when this baby is going to have been compromised oxygen supply in the mother. So it is our duty to diagnose the FGR babies more and more, and to give them nice ANC care. Now, what is abnormal umbilical artery means? Now, many a time patient comes with an ultrasound report with different Dopplers in your OPD. If you are okay with reading the report, it's well and good, because the interpretation of the umbilical artery Doppler is very, very difficult. And if patient is coming with the abnormal Dopplers in the OPD, the Doppler has to be read with the clinical findings Doppler has to be read with the ultrasound report, seen directly by the clinician. That has to be seen by a very expert obstetrician. Otherwise, baby can die in utero. Again and again, I'm telling you. So do not give them any opinion if you don't understand the doctor. Just send them to proper person. They will give them the nice understanding of the Dopplers. बिकॉज हम लोगों को प्रीटर्म बेबी भी नहीं निकालना है, मतलब अपने को जल्दी भी बेबी नहीं निकालना है और अपने को देर से भी नहीं निकालना है ताकि आईओडी हो जाए. So our duty is to balance between preterm and the IUD. That is the well oxygenated baby taking out in a proper NICU so that the baby don't have metabolic diseases later in life, or we don't give mentally challenged baby to that mother later in life. Right? So Dopplers, if you understand, well and good. If you don't understand, don't interpret it, don't talk to patients because patient don't understand anything. They will Google it, and understanding Doppler needs extreme experience. Send the patient to proper person. They will interpret it and they will decide what to do with these Dopplers. Now again, this is the Doppler. It is beyond the scope of this presentation. So we will not talk on the Dopplers. Just that patient coming with abnormal Dopplers, you have to refer the patient to a proper clinician and let them decide what to be done. Again, these are Doppler slides. Now, what are the protocols? The protocols for FGR are different. Protocols for SGA are different. Now, what we have to see? We have to see for the placental disease. We have to see for the hypoxia. We have to see for the acidosis. We have to see for the serious injuries. And then comes the death. So, it is the point one where we have to pick up the babies. We don't want hypoxic babies. We don't want acidotic babies. We don't want IUDs. We don't want cardiac ischemias. And we don't want the deaths. So, what should be the protocol? The protocol is different. The protocol is the protocol has to be according to the effective fetal weight. Dopplers comes the umbilical artery, comes the middle cerebral artery, comes the CPR, comes uterine arteries. You have to corroborate all those things with the clinical settings, with the history of a patient in the previous pregnancies, and then you have to decide where to deliver, when to deliver, what to deliver, where to ship the babies, where to keep the patient, and the rationale behind FGR has to be scrutinized. Now, what are the predictors of adverse outcome among the SGAs? The predictors for the adverse outcomes are the AC. I told you the abdominal circumference is the basic. If abdominal circumference is lagging behind 10 percentile, this baby is definitely going to have adverse perinatal outcome. Then comes the uterine Dopplers, and then comes the umbilical Dopplers. Uterine Dopplers are very little significance, but it has to be done in a case where the patient is a bad obstetric history and you need to start some medicine, say at 13 weeks, say at 20 weeks, then comes the uterine Dopplers. But in the umbilical Doppler, it is very sensitive vessel. You have to take it, you have to interpret it very crucially, and then you have to decide for the delivery strategy. That I have already told you. This I have already told you. This I have already told you. Now again, what are the optimal outcomes? What are the protocols? We need to see whenever you are doing your clinical practice. हम लोग ऐसा नहीं बोल सकते कि इतने साल के मेरे एक्सपीरियंस में ऐसा नहीं हुआ है. That is a bad answer. Why we are medicos is because why we are taking the same is because we are supposed to follow some protocols. Every nice medical practice has some protocols, and we need to go with the protocol, because if you don't go with the protocol and if something happens, then you will be caught in the court of law. But if you go according to the protocol and if you are having some adverse outcome, still you should be, or you are in a position to tell it to the judiciary that this was the protocol taught to me. I know this protocol. This is the standard protocol. I followed this standard protocol. Still, IUD happened. Then you will not be behind the bars. But if you don't follow the protocol, then definitely patient will catch hold of your collar. So you have to follow the protocols. So what are the protocols? Protocols you need to follow, because I told you for the SGA babies, usually they do not have stillbirth, but for the FGR babies, 3% stillbirths are still there, even after if you give the excellent treatment to these babies or the mothers. So we need to follow the protocol. So the protocol says for the SGA babies, delivery at the 39 weeks. FGR babies, there is some Barcelona staging. Nowadays, when you go for a Doppler reporting to a radiologist, the smart or the intelligent radiologist which will give the Barcelona staging for every Doppler. Barcelona staging is something which tells you how much time this baby is safe in utero, right? So the stage 1, 2, 3 and 4 are there. But again, I am telling you, only Barcelona staging is not everything. Barcelona staging has to be interpreted with the clinical settings. That has to be done judiciously by the treating physician, treating gynecologist, and let her decide what is the time of delivery. But broadly, the stage 1 FGR babies has to be delivered at any cost of 37 weeks. Please do not go beyond that. Stage 2 at 34 weeks, stage 3 at 30 weeks, and stage 4, this baby is already acidotic. You have to deliver the baby anytime. Urgently, this baby is going to die in utero. Stage 3 and stage 4. Do not wait any more. These mothers need admission. Any mother with Barcelona stage 1 and henceforth need admission and supervision under the obstetrician. So what are why we are having this protocol, why we are having these stages is because in the early onset, there is a higher risk of IUFD in preterm child. Rather, in the late onset, there are very less IUFDs below 37 weeks. So we can go up to 37 weeks for the late onset, but for the early onset, you have to decide according to your clinical situation. So our strategy again come to this very important slide. Detect small fetus, classify it into SGA versus FGR, then again classify it into early onset or late onset, then define the stage of severity and then decide the protocol and then decide the treatment. So now what is late onset? This is more dangerous than the early onset, is because these late onset babies have less tolerance to the hypoxia. Usually these babies have very less tolerance. Mother lands up into preeclampsia, baby go into meconium. So whenever you have FGR babies, this needs to be delivered by elective sections. These babies need not go for normal deliveries because they are hypoxygenated babies. Their tolerance is very, very less. This is again same slide. So coming to the composite adverse outcomes. If it is a term baby, that is more than 37 weeks, live birth without SGA, without FGR, the adverse outcome is only 3.2%. Adverse outcome means morbidity and in the terms of mortality. But if it is SGA baby, that is a small fetuses without pathology, they have 2.8% adverse outcome. On the contrary, if the baby is FGR, that is the small baby's fetuses, whenever is maybe the onset, the chances of adverse fetal outcome is very, very high. That is 6.5%. Out of 100, if 6 babies are dying, it's a very high figure. This is again a classification of FGR predictor poor outcome. This is again I will come to the Barcelona staging. If now how to monitor a patient. Is it safe really to monitor SGA every 2 weeks? Yes, it is safe to monitor with every 2 weeks with Barcelona stage only 1 or without Barcelona staging. Barcelona staging पे एक बार patient आ गया, please do not give treatment to these babies because there can be IUFD anytime, right? But counseling, rationality, we always can give to the patient. We have to talk to the patient very intelligently because counseling is very, very important in such cases. So SGA babies, 0 stillbirths with follow-up every 2 weeks, but SGA babies remain 91% until delivery. This is a very rationally, but you have to Now it all depends how you are following the mother. You have to follow the mother with a good NST machine, with a good criteria, with a DFMC count, a daily fetal cardiac count, with a fetal mother weight, with the fundal height and all those things. Now early onset FGR. Again, this is again the same slide with elaborate teaching about the Dopplers. We need not go into the details of the Dopplers. This is again the Dopplers. We did not go into details of the Dopplers, but you understand this right from the 20, this is a 28th day. You have to go from here. The Doppler goes on becoming deteriorating day to day. There comes the role of CTG, BPP, and in CTG and yes or no with the BPP. Again, stage 1, 37 weeks deliver. Exam intervals every 7 days. Stage 2, 34 weeks. Exam interval every 2 to 3 days. This patient needs admission. 30, Barcelona stage 3, daily patient needs admission. Stage 4, immediately. Otherwise, this baby is going to die in utero. So what we can conclude? We can conclude again the same slide. You have to be very, very monitor crucially these patients because they can have deaths any time. And all the ultrasonography reporting has to be corroborated again with NST and the clinical findings and the patient's past history. This is stage-based classification of FGR, that is stage 1, 2, 3, 4. This is a simplified slide where in stage 1, mild placental insufficiency but severe smallness. In stage 2, there is severe placental insufficiency. In stage 3 are the low suspicion fetal acidosis, and stage 4 are highly acidotic babies. We do not want babies in stage 4. We want to deliver these babies stage 2, max stage 3, not beyond that. Again, the same very, very important slides: identification, distinguishing, and decide follow-up, and the timing of a delivery. Then what is this? Shall I speak on max self? Shall I speak on max self?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
There is a role of max self. Now there is one more company. If some of you, if they are working in medical colleges, now no, this Maxell has come up in the company name is Blisson. The Blisson company has come up with this Maxell ready mix bottles. They have a ready mix bottle of 100 ml, which is giving you 4 gram of Maxell. Initially, what we have to do, no? We have to break away the ampules, mix it with that normal saline, then make a solution, give it intramuscular or IV or whatever those things. They were made meticulous. Now this Blisson company has come up with a ready mix 4 gram IV loading dose of Maxell. This is for whom? This is for in women at risk of early preterm imminent birth from viability to 30 weeks. Should be administered regardless of the cause for preterm birth. When early preterm birth is planned or expected within 24 hours, Maxell should commence as close as possible to 4 hours before birth. The optimal regimen is IV loading dose of 4 gram, which is very, very safe, administered slowly or 20 to 30 minutes. It has to be followed. The next doses, you need not go into the detail. Just if you feel that this mother, if you are referring a mother to a referral center and you think this is a baby less than 34, forget about 30 weeks. Even if she is the mother less than 36 weeks. And if you think this baby is going to deliver and she is going to take some time to go to the delivery place or a center, just give this Maxell to this mother. What this Maxell will do? This Maxell will take care of the brain maturity of the baby. Because the more preterm babies are delivered, more is their intellectual level compromise after the delivery. Most of the babies in whom it has been studied that if you give Maxell 4 gram IV loading dose in 1 hour to a mother before 34 weeks of pregnancy, you can give it up to 36 weeks. If you are not sure of the weeks of pregnancy, कोई भी उसको harm नहीं होएगा, you can give it directly. So these babies does very good compared to those babies in which the Maxell has not been given. these babies are intellectually higher. These babies will have a very less chance of mental disability, dyslexia, autism. So please, 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 whenever you get a chance of referring a mother which is less than 34 weeks and you think this can deliver, or even if she doesn't deliver, and if you give a Maxel, it is not going to make any harm to this baby or a mother. Right? So whenever you feel, just give Maxel and then refer the patient. By the time patient will reaches to obstetrician, this baby will be under a protection. Rather, if I need to go for a section, this baby will have a nice follow-up in a NSU. NSU babies do wonders, those who have given been Maxel with the antenatal period. Not in OBD, but this is for the emergency. Now the role of corticosteroids. Yes, a single course of corticosteroids, that is betamethasone. If the betamethasone is not available, you can go dexamethasone as well. It is very much recommended for pregnant women between 24 and 33 weeks of gestation, when you feel that this mother can deliver by preterm delivery within 7 days. Whenever you feel that this mother can be delivered pretermly, you can give betamethasone to this baby, 2 doses, 12 milligram, 12 hours apart. These doses will prevent those mothers from the risk of the lung prematurity. Because whenever you deliver a baby by preterm delivery, what is the more worrisome issue is the lung prematurity. These steroids work wonders for the mothers. This we have already seen. So the counseling for future pregnancies, the counseling for future pregnancies, when a woman with history of placenta-mediated pregnancy complications, including FGR, are at an increased risk of future cardiovascular morbidity, should be advised regarding preventive strategies. There can be long-term maternal implications of pregnancy complications. Recurrence of FGR is based on timing of onset, severity of FGR, and placental histopathological findings. Whenever his mother has had an adverse outcome in this pregnancy, like PH, like hypertension, like diabetes, please ask this patient to get pregnant for the next time with an interval of 3 years. Right? If the mother is having adverse outcome within pregnancy with severe preeclampsia or eclampsia, and if the patient is younger, ask her to take a break for minimum 3 years. If the mother is diabetic, obese, hypothyroid, ask her to come to their levels to normalcy, then to go for conception. Or if the mother is having bad obstetric history, in whom the rubella vaccination has not been done, or in whom you feel ANA is positive, patient is sickling, or patient is a SLE case, send her to physician, get her treated, give her all the medicines. When she comes to normalcy, then allow her to go for pregnant, so that the complications will be lesser in her next pregnancy. Now, what are the candidates for genetic counseling? The candidates for genetic counseling are in whom the FGR has been set in before 32 weeks in the absence of an identifiable non-genetic cause for the growth restriction. More than 32 weeks, risk of aneuploidy is low. FGR with major fetal structural abnormalities or ultrasound morbidity associated with an increased risk of aneuploidies, thickened nuchal fold, FGR with polyhydramnios, ultrasound findings suggestive of a triploid pregnancy. All these mothers will genetic counseling. Send them to genetic counselor, let them do the counseling, let them do their job, and then let the patient get pregnant. Because अगर कुछ निकला तो again this patient will come to you and they will ask you, why don't you send me to genetic counselor, why don't you send me to this or that, whatever things. Then in a practical scenario, monitoring and delivering early onset FGR is role of NST, like USG and all those things. Now, what is the role of all those things? These are the infections, Actually, when we are doing, a torch, IgG and IgM, no? Nowadays, it has very less significance. It has significance in very, very less clinical scenarios where you are predicting that there may be toxoplasma, There may be history of catching hold of pigeons or cats or dogs. In all those cases, these investigations can be offered. Otherwise, it has very less significance because then patient gets confused. They feel this is positive, that is positive, and they don't know the interpretation. But yes, surely routine infections serologies may not be warranted in the absence of risk factors or ultrasonographic markers for fetal infection. PCR is the preferred testing approach for CMV and should be performed in women with unexplained FGR who undergo diagnostic testing with amniocentesis. In a nutshell, what are the management protocols? Assign a correct gestational age, which is already I have told you, by LMP or by ultrasonography before 20 weeks. The gestational age cannot be assigned after 20 weeks. Identify a small fetus, do Dopplers, distinguish between FGR and constitutionally small SGA, stage the FGR and plan surveillance. Decision and on when to deliver is based on the protocols. Do not use your own protocols, follow the protocols. What is the take home message? The take home message is an objective protocol based approach to decision making is validated. Ductus venosus evaluation is the cornerstone for assessing the deliver in early onset FGR. A CPR ratio is a critical index in late onset FGR that I already told you. Scans at 36 to 37 weeks and 30 to 32 weeks, along with Doppler, are becoming increasingly justified in low risk groups. So nowadays, 5 scans minimum in 9-month NC are minimum needed, with Dopplers in the later weeks of pregnancy. They are very, very necessary because again, I will emphasize on this the medical legal era. 5 scans in 9 months from proper radiologists with good interpretation are very much needed, and rather they are mandatory. So everyone want this baby, and if everyone want this baby, please follow protocols and treat your patient nicely and give them such nice physical and mentally health baby. Thank you for the patient listen.
Wonderful webinar, ma'am.
Thank you so much.
Thank you so much,
Truly,
ma'am.
it was truly very each and every point you have explained very nicely regarding the early estimations for the FCRs. And I would like to take some questions now.
Yes.
Doctor,
Yes, ma'am, I'll get it. Thank you so much, ma'am, for
Am I
such a
seen to
wonderful
you?
session.
Am I seen to you?
No, ma'am.
I don't know, कुछ तो भी हो गया. मैं दिख रही हूँ क्या?
हाँ मैम आप दिख रहे
हाँ,
हैं.
दिख रही हूँ ना? चलो स्टार्ट
Yes,
करते
ma'am,
हैं.
you are
So क्यों?
visible.
मुझे मैं खुद नहीं दिख रही क्योंकि I don't know. Continue. We will continue.
Thank you so much, ma'am, for such a wonderful session. We have learned so much. It was very specific and informative. There are few questions which I would like to take. Ma'am, what are the hormones that are responsible for the fetal growth development?
Exactly काय म्हणायचे तुला?
Ma'am, hormones which are responsible for the fetal growth?
Actually, fetal growth has to be divided into 2 factors, 2 stages. Up to 12 weeks, it is the corpus luteum which is taking care of the baby's growth, and after that, it is the placenta which is taking care of the baby's growth. So whatever basically it's coming from the placenta is helping mother to grow, right? So ultimately, it is the nutrition, and the nutrition because we cannot change the genetics. You know? If the mother is having any diseases like diabetes or hypertension or hypothyroidism, we have to treat it accordingly. But for the baby's development, it is the nice nutrition which is very, very important for the mother.
Okay, ma'am. Ma'am, how to deal with the complications of IUGR in twin pregnancy if the one is IUGR?
Now, it all depends. Twin pregnancy, they are monochorionic, they are dichorionic, they are monoamniotic, or they are diamniotic. Again, a very, very important ultrasonography in the twins is at 10 to 12 weeks because This is the best time when we can diagnose whether it is monochorionic, bichorionic, monoamniotic, or diamniotic pregnancy. Once the baby is deciduous, that is diamniotic, dichorionic, no need to worry, they will grow nicely. But if the baby is monochorionic and diamniotic, in that case, there is more and more chance of getting one baby IUGR and one baby normal. One baby polymorphic, one baby normal. In these babies, you need again a counseling of the patient, and serial Dopplers are very, very much important for these babies. As such, we cannot do anything. Everything has to be done by the babies because it all depends which baby is taking more nutrition from the mother, right? So if it is deciduous babies, they will take equal. But if they are monochorionic babies, the things will be different. We have no hold on those babies.
Ma'am, is there any study predicting higher risk of autism child with antenatal corticosteroids?
No, no.
Okay.
Autism has no role with mother at corticosteroids. No.
Okay, ma'am. What precautions can we take in present pregnancy if the previous pregnancy of the woman had FGR?
From the very beginning, actually, this mother needs to be counseled in the antenatal time before she get pregnant. That is the best time to counsel her. Now, how to counsel her? Her blood pressure needs to be normal, weight needs to be normal. I know it is very, very difficult. Let it be. At least she should be on medicines, right? Now, if you have any reason, you need to treat it. If you don't catch up any reason, then also you don't need to treat it. Now, in these cases, you need to, if the first baby was FGR, in this pregnancy, the very important scan is at the early scan detection of a pregnancy at 9 weeks, right? Then at the 11 to 13 weeks, the very, very important scan in this pregnancy is between 11 to 13.6 weeks. And please do not dispense NTNB scan and Doppler, which is very, very mandatory. Do it. If you can pick up abnormality, it is well and good. If you don't pick up abnormality, it is normal. You can continue with the pregnancy. Keep her in nice monitoring. Keep her in nice monitoring. Do ANAPA testing. Do VTCT. Do electrophoresis. And do GTT. These four tests are very, very mandatory. Whenever a patient comes to your counseling for the first time, which is having history of FGR in first pregnancy, ANA, APA, electrophoresis, GTT, mandatory test. This needs to be done. If you pick up anything in this test, treat accordingly. If all these tests are normal, then continue it as a normal pregnancy, but keep in strict surveillance, right? If you find that baby is lagging at some time, Dopplers, you have to go for Dopplers. You have to go for nutrition. You have to go for proteins, and you have to go for a nice protein diet and bed rest.
Okay, ma'am. Ma'am, do we need to repeat corticosteroids dose weekly if we are successfully to pull the pregnancy till 34 weeks?
No, no. Single dose, 32 weeks, that is sufficient.
Okay, ma'am. Ma'am, if prevention of previous PIH with IUGR, can we start ecosprin as a prevention as
Yes.
soon as pregnancy is detected, or we should,
After 12
what
weeks.
should be the dose for that?
12 weeks. 150, they say.
Yeah. What should be the PI value of uterine artery, and when can we say that it's high in first trimester?
If we are doing a Doppler, there are two testing, pathological testing by blood test and ultrasonography. If is having any value is more than 1.5, any systolic flow in uterine is more than 70 centimeter per second is normal. Anything below 50 is abnormal. Any SD ratio below 0.5 is abnormal. Any PI 1.5 is normal. Right? Everything is written in a sonography. You just have to read it rightly. Everything comes in written. Everything reads in comparison. But again, I am telling you, it has to be done by a very intelligent person. Because PI values, RI values, SD ratios, PSV, and diastolic volume, all those ratios has to be done very, very judiciously. And one single setting cannot predict the adverse outcome. You have to compare it with the previous values and the next values. It has to be done serially.
Yeah. Ma'am, GDM and FGR relations?
Very, very bad relation. We think that the GDM babies are bigger babies. They are bigger babies. But Some GDM babies, even though they are bigger babies, no, their Dopplers are abnormal. So these babies need more counseling. These babies need more counseling. This is because at one time they are on insulin. At another place, they are at risk of FGR. At one place, they are at risk of hypoglycemia and IODs. At another place, they are at risk of IGR and high risk. Right?
How to consider the candidate for oral ecosprin or low molecular weight heparin?
You have to do the APLA screening. You have to go for APLA screening. And when the patient is positive, no, then only you have to give the medicines. Without report in hand, you cannot go for it. You can go for APLA screening, ask your nice fellow to do it, and if APLA is positive, you can start for icosprin and low molecular heparin.
Ma'am, can
Ma'am,
you
how to
little
handle
bit elaborate regarding the IGF-1 and IGF-2 and how it impacts on the fetal blood and the
Ma'am, I
fetal.
cannot listen you clearly. Will you please little louder?
Hello, ma'am.
Ah,
Can you elaborate regarding the IGF-1 and IGF-2, that is insulin like growth factors 1 and 2, means how they impact on the higher level of in the fetal blood and how it impacts on the fetal weight at birth,
itna zyada
the
we don't do
physiology
it too
of.
much, ma'am. We don't do it too much. We don't do it too much.
Okay.
Ma'am, how to handle patients with epileptics and IUGR?
Patient has to actually know all those patients which are epileptic, they should counsel you before they get pregnant because most of the epileptic drugs are contraindicated in pregnancy. So they need to meet to their physician, treating physician. They need to change their medicines. They need to change the medicines. They need to be on those medicines for 1 year, and there should not be any episode of convulsion within 1 year. And then they should be allowed to conceive. And then whatever drugs they are taking, that needs to be continued throughout time pregnancy. Because most of the drugs they are taking, no, they are not. They are teratogenic. So they need to change the medicine. If they are allowed to change the medicine by their physician, then we can allow them to go for pregnancy.
Okay, ma'am. Is oligo related with IUGR?
Yes, very much, very much. But the IUGR, that is FGR babies, management is different. Nowadays, oligo management is different. Nowadays, it is said that even a 7 centimeter, because as as there are more and more environmental factors causing infertility and IUGR, more mothers we can see with AFI 7, they go for 1 month, right? So only oligohydramnios or AFI less than 7 is no more a criteria. Now they have come up with 5 AFIs also, okay, they say. But along with other factors. Only liquor less is not the factor to decide the delivery. Liquorless, that is oligohydramnios you are saying, along
Yes.
with blood pressure, hypertension, bad obstetric history, abortions, all those things needs to be taken care of. Then you have to decide the mode of delivery for this patient. The only liquorless does not have any significance as such. That has to be read along with the clinical findings and the Dopplers.
Ma'am, what care we can take in case of cord around neck to avoid IUFDs?
Actually, now the consensus is the ultrasonography people are not supposed to write cord around neck in the ultrasonography report. This is because there are two reasons. One is cord around neck. See, the baby is this longer. Cord is this longer. So some or the other place cord is going to be there around the neck, right? And the significance of cord around neck is if it is tight, then can cause IUFD. If it is loose one, let it be there. It doesn't have any significance. But if the sonography person has written loose loop of cord, then fine. He doesn't write it. He just write cord around neck and the patient gets panicky. Cord around neck as such is not an indication for cesarean section. Right? Cord around neck with NST abnormal is an indication for cesarean section. What max we can do, if a patient is coming with a report of sonography with a cord around neck, actually they are not supposed to write it. It is from apex body. The sonologists are now not supposed to write cord around neck, but still some are writing. That is their issue. But this is how we can counsel the patient. Only cord around neck is not an indication for section. Cord around neck has to be tight. And who will decide that? That will be decided by the NST monitoring. But yes, we can ask the patient to be conscious or cautious on effective fetal weight counting. That is DFMC, daily fetal weight counting. She can feel the kicks. If she is not feeling kicks, or if she is feeling too many kicks, that means baby is getting hypoxenated. She can consult a doctor. That is how we can counsel her. But as such, cord around neck, no need to get panicky for that.
Okay, ma'am, one last question.
Yes.
Nowadays, dual marker can be done with PE and SGR and IUGR markers. Is it reliable, or should we ask the patient to go for these marker studies?
This is very, very reliable. This is very nice, but it's very costly, dear. It is very costly. So it is not needed in all patients, no? It is not needed, actually not needed. These two things have different indications. NTNB scan, that is nuchal translucency and laser bone, it is mandatory for all the patients, right? But the preeclampsia scan or the eclampsia scan, that has to be done with the Dopplers. It is mandatory for only those which are elderly mothers or which are having adverse outcome in the previous pregnancies, because that needs a lot of money from the patient's pocket. So you cannot offer all the patients to all the patients. So you have to offer the test very judiciously to which patients needs what, because this money saved can be used for another nice test. In a normal going pregnancy, the first Doppler which you can offer to a patient is at the age of 20 week scan, if she can afford. If she cannot afford, डायरेक्टली 32 वीक्स पे डॉपलर ऑफर किया, दैट इज मोर देन सफिशिएंट. इफ पूरे 9 मंथ्स में आपको कोई एक आध समय डॉपलर उसको ऑफर करना है, बिकॉज वी नो आवर इज अ वेरी पुअर कंट्री, द राइट टाइम इज 32 to 34 weeks for doppler. Normal scan is 20 weeks and the early scan 11 weeks. These 3 scans हम लोग कर सकते हैं minimum possible.
Okay, thank you, ma'am.
Yes, thank you.
On behalf of NIMA OBGY Society, I would like to express my gratitude to NIMA OBGY Society and Central Bearer Officers, Dr. Kamini Dhiman ma'am, Dr. Priyanka Nakde ma'am, Dr. Vishnu Bhavne sir, and Dr. Rajesh Utane sir for their guidance and support to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Monali Dhole ma'am, who took time for their busy schedule and deliver very knowledgeable and wonderful session with us. Thanks to all NIMA OBGY office bearers. I would also like to thank Dr. Girish Daga sir and Dr. Prajakta Patil ma'am for all their help and guidance for the technical support. Last but not the least, I would like to thank from bottom of my heart to all the delegates for their participations. Without all of you, this webinar would have not been possible and successful. Thank you all for attending and hope you all have learned and gained immense knowledge from today's speaker. Wish you all a wonderful good night ahead. Now, with due permission of all dignitaries, I am conducting today's webinar.
One second. I just wanted to speak something. So, Dr. Monali, thank you very much for the wonderful presentation. We are very much blessed, I think, to have you as a speaker today. And this is definitely going to help us in treating fetal growth retarded pregnant women. And we will definitely precautious with this information and would definitely treat the patients well. So
मुझे भी कुछ
thank you
बोलना
very
है,
much.
मुझे भी कुछ बोलना
बोलो
है
बोलो मैम बोलो
यार.
प्लीज.
आई एम सो थैंक यू शरयू, इतना अच्छा वेबिनार और अच्छे लोग सुनने को मिले. आई एम सो थैंक यू. इट इज सच आई एम टेलिंग यू, वेबिनार इज सच अ गुड थिंग, नो? वी कैन लर्न मेनी नाइस थिंग्स राइट फ्रॉम होम, है ना? एनी बेसिक थिंग्स, एंड आवर अल्टीमेट एम इज टू हैव सेफ प्रैक्टिस. This
So
is so
that's the thing.
nice.
We are actually all the credit goes to Priyanka Nakade ma'am, that she is doing a very wonderful job.
Yeah,
And
yeah.
so she has included all the general practitioners also to listen this program. And because of that, they will definitely help all the pregnant women, whichever coming in their OPD, and these small problems or maybe bigger problems also like preeclampsia or this fetal growth retardation, they can detect earlier and can refer to those patients to a higher center. And this is a very crucial thing that should be handled on GP's level. So Priyanka ma'am, Nakade ma'am, really doing very powerful thing and great thing that she want to educate all these GPs, and for that she is organizing these lectures. So I
Very
think
nice activity. Very nice activity. Thank you so much, ma'am. Very nice activity. Keep doing it. Keep doing the good work.
yeah,
Thank you,
and we
Mama.
definitely would like to organize a couple of webinars more with you, ma'am, if you have
Please
time
go
later on.
ahead. Please, please. This is the comfortable time for me. If you want to speak me on any topic, I am anytime ready to speak on it.
Okay, okay. Thank you very much. We are really very grateful. Thanks. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you,
Thank you.
Akash sir,
Thank you.
also for the technical support. Thank you, ma'am.
Thank you.
Bye. Good night. Bye.
Good night.
Thank
Bye,
you.
bye, bye.
Thanks all of you. Thank you.